Riva, like I said before, thank you for doing this. I really appreciate it. I think actually when Jay and I first started talking about this, I wanted to get a nurse on here for a couple of different reasons. The first is that a lot of the students that take my microbiology classes are on a nursing track
Yes.
and will definitely be interested in this. And I think a
Yeah.
lot of people will. And then the second reason is because it's, as we were just talking about, it kind of falls into this umbrella of professions that I was completely naive about when I was, 18 to 25. And I kind of regret that. I think it's a profession that I would have seriously considered. And it's also a profession that I've seen people kind of later in life seriously consider and transition into. We can talk about that. I don't know how true that is, but I know at least a couple of people who did that like in their 50s. And I think they did it because they got to a point where they were like seriously evaluating how their value system aligns with their job and recognizing that it didn't, and looking for professions where it might be more likely that somebody's values align with their profession. I think nursing might fit that bill. So for all of those reasons, thank you. This is gonna this is gonna be fun. I don't quite know where to start, so I guess I'll let you kind of tell me a little bit about how far you are into nursing and your specialty. What I know from our relationship on Facebook is that you are a cardiac nurse specialist, but also with some ER practicing as well. I think you're still in the Northern Nevada area. Is that
Yeah.
right?
Yep. I'm still in Reno. I came back in 2010,
Hmm.
if my memory serves correctly, which sometimes it doesn't these days. Um, and immediately started nursing school. But yeah, the bulk of my experience is in cardiac ICU. I was one of those weird ICU nurses that liked floating to the ER, but I also have ADHD, so it kind of makes sense. Because there's two different kinds. Some ICU nurses absolutely abhor the ER. It's not structured enough or protocoled enough for them. And then there's other ICU nurses that, yeah, love it. Let's go. I've done psychiatric nursing, more so at an executive level, but I'm the type of executive that I still, if we're short staffed, I work a shift. So
Hmm.
I learned a lot of psychiatric nursing doing that. Nurse all throughout the pandemic. And I've done administrative, like I said, executive. Right now, I'm teaching full time while
Oh,
I'm finishing my doctorate and finishing the last little bit of my FNP, kind of at a transitional point for me in terms of the aspects that I've looked at in nursing and kind of with my research now where I'm making a pretty big divergence from kind of my path so far.
yeah. That's really cool. I didn't know you were working on your doctorate, or maybe I did, but it just didn't click with me.
Yeah.
So this is a research-based PhD, or
Nope, it is a doctorate of nursing practice. So I'm in the
doctorate of
advanced
nursing
practice
practice?
track. And so for us, I think the PhD, the research-based doctorates will generate evidence-based practice research. And then those of us that are doing the DNP track take the current literature and material and our projects translate that into evidence-based practice itself.
Got it. Okay.
So PhDs will create the research and then we figure out how to collate that and digest the material and solve some kind of initiative or problem by translating that into practice.
That's really interesting. Yeah, to be honest, I didn't even know that existed.
Yeah.
Yeah, so I didn't either. So do you mind if we maybe take a step back because you kind of you kind of mentioned a lot of different things. Like so for me, for a nurse, I guess I have some like a certain type of work in mind. What are the different nursing options? Because I guess I didn't even necessarily appreciate that there are administrative nurses. I don't know why I didn't think of that, but
So for
like
nursing, you typically have there's a slight difference by license.
okay,
And you have licensed vocational nurses or practical nurses. who are nurses. Their scope of practice is just a little bit more limited, and it varies, of course, state to state. And then you have registered nurses. They're professionally licensed nurses. And the scope of practice is pretty much universal from state to state with just slight variations. And then you have advanced practice nurses who in many states, I think about, don't quote me on this, I'm thinking approximately like maybe 22 states in the US, we can have autonomous practice. And there are different types of specialties that are not advanced practice, but they are licensed with a different scope of practice than a registered nurse. So it's kind of like a spectrum, if you will,
Okay.
with branches that go out, just depending on your specialty. And administrative and executive functions. So I was a chief nursing officer for 2.5 years, and that's an executive function. Like I said, as a chief nursing officer, I will always be a nurse. So I'm still the kind of person that, I'll show up in scrubs and work an actual shift on the floor, a full 12. They won't ask my team to do something that I won't do. And then there's administrative roles, which are anything below a chief nursing officer to nurse manager. So you have managers, directors, executive directors. Anything below a nurse manager is usually considered like floor staff. So you have supervisors and charge nurses and floor nurses.
And so this track that you're on now, where you're working to get your PhD, so then would you be looking to create new policies on how to treat certain conditions? Is that kind of the
For
or
me, my primary goal in terms of licensure is my nurse practitioner. I want to open a practice here in the Reno community in family, which most of the people that know me are kind of flabbergasted by that because most of my work is in acute and critical care, but in family. And I'm probably going to add psychiatric components onto that later because I really want to have a holistic practice that blends a bunch of different aspects of care for the families here and specifically our underserved populations. So our LGBTQIA+, people of color, our Black communities here, there's a huge need. There's a huge need, a huge gap in care for provision.
so the idea, so instead of going to like a primary care physician, they would come to see you. Is that the idea?
Yeah.
I see.
So that I'm really looking forward to. It's going to take some translation in the state of Nevada. You have to do a certain number of hours before you can work more autonomously. So I'll spend probably the first year, working with a physician, kind of like a transition to practice kind of thing. And then, then I would be considered a primary provider. And like I said, I haven't thought yet whether I want to add the psychiatric components onto it. I think I do, just because of the continuum of care. And for families, it is very difficult for them to find and access care if they have to go to more than one place, both for insurance coverage, because mental health is treated so vastly differently than physical health. So if it's a one-stop shop, then I get my hands on the patients for longer and can meet more needs without duplicity of charges and insurance billing and trips and time off of work, and nobody can afford that kind of stuff. So if we can get all the family in and see them for pretty much everything they need, of course, if there's, specialization or if there's things that a physician needs to, evaluate, obviously, we send them and refer them to the appropriate care. But for the most part, hopefully being able to have a place where families can get the care that they need safely.
That's incredible. So there's a few things I want to make sure that we cover, Riva, and I guess I would love to know a little bit about your route into nursing. I don't know if there is a traditional path into nursing. I mean, I guess the most traditional would be students that identify it as a career choice early on in college and then make that decision. But like I said before, and kind of introducing you, I think a lot of people don't do that. So how did
Yeah.
you get into this
So
field?
I guess I would actually be considered a non-typical student because I started, I think I was 30 when I went to nursing school. So initially, the path that I wanted to take in my 20s, I went through a couple different degrees before I settled on, it was aerospace engineering and then psychology. I think there's a couple different degrees that I looked at and went through, and I wasn't diagnosed with ADHD until I was 29 either. So I think that that probably had something to do with it. But when I finished a degree in psychology, I knew that I wanted to help people. And the only thing that I was kind of driving me was trying to figure out how to help people like myself. And I looked at marriage and family therapy and got about a semester into my master's and was like, I'm really a kinesthetic person. And this doesn't connect with how my sense of how I want to help people. And I also knew that, I don't know, being a physician just didn't feel like how I wanted to help people either. Love physicians. I just think that I'm not geared in that manner. And so I looked at nursing, and being very physically active and being hands-on with patients 99.9% of the time really gave me a sense of being actively engaged in helping patients. And I had a lot of prior experiences in my 20s that meant that I could really meet patients where they were at. I was very well geared for working in the ICU and the ER. But yeah, there was a mixture of people in my cohort that when I started nursing, very early 30s or very early 20s. We did have a few people that were like mid 40s, I think, in the cohort. It is far more normal now for people in their late 30s, 40s, 50s to be in nursing school than it was even, 14 years ago. But it wasn't entirely out of place 14 years ago either. Yeah, I would say the bulk of us were 28 to 31.
When you came to the decision to apply and go to nursing school in your late 20s, around 30, were you equipped for that application? Go back and take courses? I'm a little naive about what's required to get into nursing school.
Yeah, so the massive amount of science that I had taken in my early 20, transitioning from teen to 20s, a lot of science is time out, if you will. I don't even know what to call it academically, and I probably should, at about 10 years, and some maths and sciences at about 5. So there were courses that I didn't have to repeat, OChem being one of them. But I did repeat others. Micro was one of them. And just some other basics. I first started with my associates. So that's the other thing, that the pathway into nursing, associates of science degrees, you'll take 90 credits, and that fully prepares you to sit for the board. So it's all of the maths, the sciences, the anatomy, physiology, little to no electives, and maybe 9 credits of like your basic English, your basic math, your basic history, maybe 3 in government. You've got maybe a very bare bones like first year of just the basic core classes that are required for like a bachelor's, and then everything else is all the science, math, medicine, anatomy, all that kind of stuff. And so most nurses will do an ASN. We did an accelerated program and then become a registered nurse, and usually do a 3-semester conversion into their bachelor's. And some nurses don't. Some nurses have their associates of science, and the conversion credits, the 30 credit difference, is not particularly applicable to enhancing your bedside practice in terms of technical or practical knowledge in that matter, because you've already learned all of that. But it is more preparation and kind of, mental exercise and academic preparation for those that do want to advance onto a master's or further in the graduate track. So those 3 semesters are a good transition between really applicable didactic knowledge and preparing you for a little bit more of that cerebral academic knowledge heading into the graduate tracks.
So tell us a little bit about the nursing school experience. I don't really know what happens in nursing school. I imagine
Are you sure you want me to do that?
as raw as you're willing to do it. Yeah,
okay,
yeah, absolutely.
Yeah. All of us nurses joke about having PTSD from nursing school. Nursing school, okay, let's just put it this way, because you know me, you went to high school with me. School had never been challenging for me. Aerospace engineering wasn't challenging for me. Having ADHD and getting the right classes on time was the challenge, the executive function part. Nursing school gave me a run for my money. the sheer amount of information that you're responsible for, and knowing A, that you have to pass boards, and B, that once you do pass the boards, you're responsible for a human life. Now, we're not trained at the level that physicians are. That amount of knowledge is just incredible. But nurses, we get very close. There's a reason that it's considered such a hard undergraduate degree. We don't specialize in fields. You don't do that until later in your practice, or, you know, whatever it is that you decide to go into once you are a registered nurse. But you have to have all of that innate knowledge in order to become a registered nurse, because you can't learn any of that stuff while you're learning how to do the technicalities of physical patient care. So there's like two things that you have to learn: the academic side and the understanding of anatomy and physiology and the systems and the applications. And there's this weird type of thinking that has to change in your thinking that has to happen. Being an instructor of BSN students now, it's totally seeing it from behind the mirror. And I was one of those students that struggled with that change in thinking. I'm like, no one thinks like this. Why do you give me a test that has 4 correct answers and I have to decide which one of those is the best correct answer? That is neither logical nor sensible. Like, what are you doing? Like, who writes tests like that? But there's a reason for that, because we may have to do all 4 of those things at once, but one of those has to be done a millisecond sooner. And it requires a real change in how you think and what critical thinking means to you based on the context in which you're critically thinking.
So would you say that it's not only teaching you certain types of content, like facts with respect to anatomy and all that, but it's also changing the way that you think to help you function better?
It's fundamentally changing it. You don't ever go back to thinking the other way. And depending on what specialty you work in, the more specialized you become. I've caught people, you know, at the very start of having an MI in a grocery store. It's like a spidey sense that you develop, and then you prioritize your actions, and it's like unraveling string theory in your head while you're trying to take in data at the same time of which are the possible outcomes, which one do I have to stop first, what am I applying in order to do so, and, you know, putting all these things together. So the students have to learn to do that. It's not, we use Bloom's taxonomy in terms of rote memorization is, you know, you tell me, I remember it, I spit it back out on the exam. I have a basic fundamental knowledge of understanding that, but it's more so just rote recall, all the way up to being able to evaluate after analyzing and applying and demonstrating understanding of a concept.
Yeah, I would imagine that there's a very common misconception that going to medical school or nursing school is really about that rote memorization and the spitting back out of facts. And what you're describing is something very different than that. I mean, that's an element of it, as you just mentioned, but this idea of navigating a decision tree and really critically thinking by observation and then reformulating your prediction based on that observation is much closer to true critical thinking. And I think I would wager that's a common misconception.
There was a lot of students, I feel like, who were 4.0 students because they had a photographic memory, or their intellectual capacity for, you know, remembering things and not necessarily spitting them back out. It's not that that's a cheap trick of any kind, but just they could take the information in and put it in a filing cabinet and then bring it back out when it was necessary. I think that was a huge frustration for many students that were like that, because you build a layer cake. You have all this information and you can't forget any of it because you're building something with it. And at the end, when you sit for your boards and when you actually step on the floor to practice, you have to access all of those different layers, and they're all interconnected. So there isn't a point at which what I learned in, you know, freshman, second semester kind of sits compartmentalized somewhere. I had to take it with me and keep plugging in or keep layering pieces in third, fourth, fifth, sixth, et cetera, semesters in different disciplines. So whether it was psychology, whether it was maternal child, obstetrics, critical care, all the various different med surges, And it's hard to get students to get out of that compartmentalization. I struggled with getting out of that compartmentalization because I would hyperfixate on getting that bucket correct. And then now I have another bucket, but now they're all supposed to fit in one bucket, and how do I get all of it correct?
So is there a fairly high failure or dropout rate?
I would say yes and no. If you make it into nursing school, a lot of the admission processes are pretty taxing, and you get through your first semester or so, there's this kind of, I don't know if it's Stockholm syndrome or what it is, but this weird tenacity that will push people to hold on for dear life until they make it to the finish line. And there are other people that at that point, usually like either midway through anatomy and physiology or after their first like med surge adult health 1 benchmark, realize this is not for me. Like I can't, this is not how my brain operates. This is too stressful. This is too hard. And there's nothing wrong with that. It either fits you or it doesn't, and it doesn't ever change once you graduate. That level doesn't ever change. And if that's not something that's healthy or okay, or how you most productively function, then don't do that to yourself. You know, I mean, that's
Yeah, so it's kind of like a boot camp. I'm just trying to think because I like to think about either personality traits or certain things that if you were to give advice to younger people or to anyone who's thinking about like going down that road. Because again, naively, I'm thinking nursing is going to draw like very compassionate people. But there's a variety, like obviously there's just a variety of personality traits that you need to have to succeed. So kind of hearing this kind of boot camp element to it is a little bit surprising and very interesting.
Yeah.
So I didn't know if like can you can you spot like if you were to shadow an incoming class, like do you think you could pick it out, like, oh, this person's gonna fold under
Yeah.
the pressure, like
Um, I think that when it comes to personality traits, one of the most common ones that signals to me that either a colleague or a student is healthy as a nurse or is somebody that will do well in nursing is someone that has the ability, they're very comfortable with independent thought, because we never know all the things. So you're always kind of 1 foot in unknown territory and 1 foot in, okay, I have protocols for this. And nursing school is no different. But somebody who is okay being in that position and can either hunt down the information or ask about the information, they're not afraid to not know. And in their independence or their autonomy of self in terms of, okay, well, I don't know that. I can go find it. There's a textbook that has it. There's a preceptor that has it or a protocol. I can go find it. And being in that uncertainty and being okay with it, I think is, I don't even know if there's a name for that kind of personality, but that ability to do that is really a strong indicator. Not that you're not uncomfortable doing it, but that you can and you do. And the other thing is definitely compassion, because going through nursing school, the compassion that you have for each other, it is like a boot camp. I mean, we're all colleagues, and your nursing team, your nursing, you know, the people that you work with, the people that you went to school with, are you really have a strong bond.
yeah.
And compassion for each other and seeing the levels of stress, the levels of overwhelm. I mean, I'm sure, you know, I'm sure there's a ton of other disciplines that have the same thing, of course. And it really is an indicator of being able to bond and being able to see others' perspectives and connect with that. The people that struggle with that don't do well. And I'm not saying that you have to be, you know, highly social. I'm neurodivergent. A lot of nurses, so many nurses, oh my goodness, so many nurses are neurodivergent. You don't have to be. I'm not talking about being socially adept or socially awkward or anything in that sense, but just the ability to feel empathy and compassion for one another. You have to have that in nursing. Nursing is not altruistic, and that's a really negative stereotype that's out there, but you have to be able to view another human being that you know nothing about and have the empathy and compassion for whatever situation or context that they're in.
So just kind of building on this and thinking about traits, I'm going to think about my sister here. My sister is a nurse as well. Now she's in more administrative roles, but she has a nursing degree and practiced as a nurse for quite a while. And she certainly has the empathy and the compassion. And she also has what I would describe as the ability to kind of take control of a situation. And I don't quite know if those are the right terms, but somebody who is both warm and authoritative at the same time. So you can kind of, by your actions, convey implicitly that you're a leader of the situation. And I kind of see these same traits in you, Riva. That's not something that everybody conveys. And I would think that that's probably something that is inherent, or maybe you can develop it. I don't know.
I think you can develop it. I think a lot of that has to do with how nurses are empowered. Unfortunately, the adage, nurses eat their young, is not just an unfounded stereotype. I've been researching horizontal and lateral violence in nursing for, what is it, 2025, for about 6 years now.
Sorry to interrupt you. I'm just
No,
not
that's
familiar. What are you referring to? I'm just not
So
familiar.
there's a saying that nurses eat their young. And in nursing, there is a I'm not even gonna say unique. It's just a phenomenon in the culture of nursing where bullying, the
Like
research
A's?
term for it is lateral or horizontal violence, but bullying is endemic to the culture.
Really?
Yeah. It starts in nursing school, and there's a very specific reason why it happens, but for people who innately don't like conflict or handle conflict very well naturally, you either stay a nurse or don't stay a nurse. And that is through no fault of their own. That's not a fault of their own. But you learn to have it's our therapeutic communication and therapeutic boundaries are both vernacular and action. Like, we have to maintain therapeutic boundaries. So our compassion and our empathy stays within that therapeutic boundary, but our ethical and professional obligations require that we have the backbone to do what is necessary to protect our patient, to provide for our patient, to advocate for them in any circumstance. And depending on where you work, the spectrum of how you do that varies. So you may have nurses that work in fields that are not as aggressive as like maybe the ICU or the ER. And aggressive is probably the wrong word, more so just constant high stress.
Mm.
Who may hold that therapeutic boundary in a different way than, say, an ICU nurse would. And nursing, the amazing thing about nursing is you can have somebody that's a nurse for 30 years that's been in like 9 different fields. That's the coolest thing about it, is maternal child, research, informatics, med surge, home health, population health, epidemiology. I mean, I wouldn't say that it's endless, but nurses are really getting creative on what areas their brains function best in, and how do we improve patient lives? How do we improve patient outcomes in that niche? So even more fields are developing now. So you have to have that autonomy and you have to have that backbone. How you express it may look a little differently depending on what area you're in, but you have to have it. And if you don't have it, or unable to cultivate that, it probably isn't the right career for you, because you're gonna feel miserable. It's not gonna feel like a good fit.
I want to make sure that we talk a little bit about what life on the job is like. And not quite sure how to start this, but one thing that I've been becoming increasingly interested in lately is how and we don't need to start here, but I'd be interested to hear your perspective. I'm becoming interested in how professions treat your body. And
Oh,
and the reason is this. A lot of people in my profession spend a lot of time sitting in front of a computer, and
Mhm.
I have actively like distanced myself over the last few years from doing that. And I think it's been great. I spent a lot of time walking and thinking, and all of that is because I think that there are some professions that are inherently better for how our systems have evolved and are inherently better for this balance between cognition and physiological health. And that's a huge spectrum. However, some professions are very, very hard on one's body, and some are not. And some are actively promoting health, and some are not. So I'm kind of interested in your thoughts on that for the nursing profession. Like from a physical perspective, what is it like to be a nurse?
Well, again, the field that you work in definitely determines to some extent how physically demanding the career is. But as a baseline, if you were to just take a bedside nurse, that works in the bedside at a stack hospital, float pool, tele, med surge, it's physically demanding in that you're constantly on the move. We do not sit down and play cards. So you're usually, sitting briefly to chart, or especially in telemetry, usually you're walking and charting. Most of the computers are mobile. In the ICU, especially as a member of like the code response team or rapid response team, there were nights in the cardiac ICU that I would hit over 20,000 steps easily in a shift. You're just flying, you're going. The ER is very much the same way. Med flights and care flights, that's a totally different type of physicality, but it is very physically demanding. And we as nurses, we know full well that we usually don't do what we tell our patients to do in terms of hydrate and go to the bathroom. So nurses have astounding bladder control for, 8 to 10 hours. And are probably dehydrated and drinking too much coffee. But while it's physically demanding, it's also physically rewarding. A lot of what nurses do in terms of lifting patients and moving patients. Ergonomics has been something that's been studied very heavily in the past 10 years because there was such an impact to nurses physically, by the time you'd been a nurse for 10 years, that now they have everyone, when you're onboarded at hospitals, has really good training in ergonomics and lifting and, mechanics to protect yourself on the job and work smarter, not, work yourself harder in terms of patient care.
Are there regulations and rules around shift hours? Like, especially I'm thinking overnight.
The state that you work in, so like California, for example, California has ratios, so patient to nurse ratios. There's not a lot of states that mandate those. And California, you have to have your lunch break within X amount of time from the start of your shift. And you also have to have a certain amount of breaks, 15-minute breaks in your shift. They have break nurses that will cover you. That's California. That's over here. Other states, Nevada does not have patient ratios. It's kind of commonly regionally accepted, the number of patients that you have. The ICU is one place where it's almost always either 1-to-1 or 2-to-1 due to the level of severity and need of care. But telemetry here can have 7, 8 patients. Med surge here can have 10 to 12 patients, and so forth. Telemetry in California has 4, and I think med surge has maybe 5, maybe 6. So it really depends. But as far as the shifts are concerned, yes, the standard is about 12 hours. You can work 8s. Some of the federal jobs have shorter 8-hour shifts. You can work up to 16 hours, but you have to have a certain amount of hours in between. Like, let's say you work to 16, you can't come back to work to start another 12 until 12 hours have passed.
And what about like PTO and things? Like, I know a lot of people are very like do you need to is there a pecking order in terms of seniority for who gets, like, do you have to work a lot of holidays when you're first starting out?
No, it usually, like as a CNO, I had alternating holidays. So if there's like 7 major holidays that we put out there, people will put requests in, they'll list them by their top 3s. We'll pick them. Usually these calendars are usually published like 6 months ahead of time if you have your scheduling together. And then the following year it flops. So if you worked, Christmas this year, then next year, you'll have it off. And that's the most common type of like holiday scheduling. There are self-scheduled hospitals and there are scheduled hospitals. There's proponents of both sides in terms of which is better and which one nurses like better. Consistent scheduling is another thing. So set scheduling is what it's called. And that means that like when I was in the cardiac ICU, I was a single mom. So I worked Friday, Saturday, Sunday night. And I worked that schedule for close to 3 years. But that allows your staff to know 6 months from now exactly what days they're working. So they can plan their PTO, they can do that. However, the self-scheduling, you publish 12 weeks of a schedule at a time. 6 weeks before that schedule is supposed to roll out, you put the boards out, people self-schedule themselves wherever they need to be. Then the scheduler will take it back. They'll lay everything out, look at the number of beds, the number of acuity, and how many nurses they need to fill. And they'll start filling in the gaps or adjusting people slightly as they need to be. And then they'll publish the schedule. And if your schedule was adjusted and you needed to have that time off, then you'd put in a PTO request or you would shift swap with somebody.
So getting back to kind of the physical aspect of the job, I'm thinking about how nursing could appeal to me. I kind of envision nursing being one of these professions that is multidimensional in the sense that while you're doing physical tasks, these tasks are also kind of juxtaposed against cognitive tasks. You know, you're navigating a protocol, you're filling out a chart, while at the same time, kind of the third dimension is the social aspect of it as well. And I don't know, those types of jobs, I think, kind of appeal to me as being the most rewarding because it's engaging you on all of these different fronts and it prevents stagnation to some degree, but it also allows you all of these things that I think humans are designed to do, and that's use our brain at the same time that we're using our muscles. Would you say that that's kind of true, or?
You nailed it, actually. It doesn't matter where you are in nursing. You are physically providing an intervention while mentally thinking, planning, evaluating, thinking around the corner and listening to what the patient's telling you or what the data is telling you while you're doing both of those things and being therapeutic. A huge part of our ability, anybody can do what a nurse does in terms of the technicality of intervention. If you're trained to start an IV, you can start an IV. The thing that really is part and parcel of like the crux of our ability is that therapeutic engagement and interaction with the patient while we're doing the technical and physical things. I mean, you don't interact with a nurse for funsies, like, yay, I'm at Disneyland, like you have a need, whether it's a school nurse and you're a sick kiddo, or whether you are an oncology patient on hospice, whether you've had a really bad day and you're coming down my trauma elevator, you're doing it because you have a need. And our training centers that need while we're also trained to do these other things kind of as a Rolodex around it. And it's exhilarating, it's rewarding. Yes, it's exhausting, but it's so are careers. I mean, that's just, that part's just life. I wouldn't say that nursing is any more exhausting than anything else. I am biased, I think, when I say that I think it might be more rewarding than a lot of things, but it is exhilarating to just see the light re-enter a patient's eyes, when they get a spark of hope or when you resuscitate somebody. Or even kids that are not afraid of a treatment because you have made it fun. You've taken the fear out of it. Or patients that are able to ask questions and you hear this sense of empowerment in their voice when they finally understood all the medical mumbo jumbo. They suddenly feel like, okay, I'm retaining ownership of myself again now. I'm not, I'm not confused or not understanding, what I'm supposed to do with my own self. There's just a million different ways that all of those things intersect. And yes, you're on your feet and you're physically doing stuff at the same time. But that's one of the most rewarding aspects, I think, of being a nurse anywhere that you're a nurse. Even in administration or executive tasks, we're constantly circling the hospital, rounding in the hospital, running around the hospital. Our staff probably wishes we weren't as much, but we are.
I would imagine there might also be this kind of misconception is probably not the right word, but this idea that you have to be okay riding an emotional roller coaster, which maybe at first that's true, but I think it's probably more true, and correct me if I'm wrong, that you need to be able to manage an emotional roller coaster and kind of like somehow like move the peaks and the valleys closer to a baseline. Like I don't know how if I'm explaining things.
You are that is my doctoral project is looking at the resiliency of nurses, because there's so many factors that are impacting the resiliency of nurses. And that results in job and burnout and all this other stuff. But you don't have to be okay. And that's not human to be okay. I tell all of my students, all of my new grads, my team, like, no matter which group of nurses it is that I'm talking to, the day that you don't feel these emotions, the day that you don't have emotion about something, I want you off my floor, because you are dangerous now. The day that something doesn't impact you, you have a really hard question to ask yourself, whether that's happy or upset, either extreme. Nurses, that the crux of the problem is that we are taught to nurture and be therapeutic and do all of this stuff externally, but there is no component in our training that is at us. How do we handle our own emotions? How do we heal ourselves? It's all external. And that literally is like the entire subject of what I'm pivoting to right now in my life. But the resiliency, you have to be able to maintain equilibrium, which is pretty much the definition of resiliency, handling adversity and maintaining an equilibrium. That doesn't mean, though, that you become anesthetized to your environment or the context that you're in. It just means you either have really bad coping mechanisms and suicidality and addiction, and those are very prevalent in nursing, or you learn healthy coping mechanisms to become very self-aware and emotionally intelligent with regards to yourself, because we're taught to do it externally. We're so taught to do it externally, almost like it's like a seventh sense that we develop, but we're not taught to do it internally. And that is a struggle for nurses, because we have to admit that we're not okay in order to start the process of learning how to bring the scales back to level.
Is there a support system in place for nurses internally, like within hospitals, or?
There's supposed to be, and it depends on where you work. Again,
And if there is there a hesitancy by nurses to kind of come forward? Like, do they worry that they will either be put on leave, or there'll be I don't know, a stigma associated with them in some weird way? Is that
immediate? Yes.
Yeah.
For you two not being nurses, you guys are very nail on the head with your perspective of where you're seeing realities about nursing. The stigma about it is exactly why I've been able to do 6 years of research on it, because nurses, you can't, and this is false. Anyone listening to this or watching this, what I'm about to say is the not true part. Right. You can't be the weak link. You have to be ironclad. And I don't care what genre you work in. It's not just the big bad ICU or the ER or whatever. Any genre of nursing, because there's so much implicit trust placed in us, that lie about nurses being, that this is altruistic and it's it is who you are. It is a profession. It is an academic and intellectual and physical profession that you study for, that you do everything else that everyone else does in professions. It is okay to not be okay. That doesn't mean that alters any ability for people to put trust in you. But that stigma, 6 years of research later, and I'm not entirely sure where or why that was created, but we're working very hard to educate the younger generations of nurses that they have to take care of themselves because they cannot take care of anyone else if they do not. You can only pour so long from an empty cup before it disintegrates. And the burnout and the nursing crisis, we're hundreds and hundreds of thousands of nurses short just on the West Coast, never mind like the entire United States, is because generationally there was this unspoken paradigm really of, you will not crack. That's why you hear so many nursing stories about nurses, crying in the linen closet or crying in the supply closet or being really maladaptive in terms of just compartmentalizing everything. And that's where the weird twisted senses of humor came from. We're teaching the younger generations now that there's nothing wrong with having the emotion. It's what you do with it that is either healthy or needs to change. And there's a huge stigma with speaking up, with admitting that you have any kind of mental health issues or problems. The younger generations are so much better at it, about talking about it, about being open about it, but the systems are still, they're changing very slowly. They're changing, but they're changing very slowly.
Well, I would imagine one of the real challenges here is that it is a challenging field, right? From an emotional perspective and all these other perspectives as well. But at the same time, those challenges and your passion for it gets this like hook in you, right? And maybe keeps you there longer, or keeps some people there longer than they should be there, because they're just so engaged. And that hook is something that's not so easy to tear out of them. And so I can imagine that there's times for an off ramp where somebody should, because they're genuinely too far past the burnout stage, get out.
Yes.
But I can imagine it being pretty hard in nursing to do that, to take that step.
Yeah, being a nurse, you are that 24 hours a day, 7 days a week. And whether you're working or not working, that part of your brain, that change to your thinking is just present. But nurses need to realize that they can move laterally. All of those years of experience and technical expertise and passion in a particular field, or passion with patient populations. My sister in California, not one of my biological ones, Frank, but sister from another mother, loves working with geriatric populations, and she's just the most phenomenal nurse. I went to nursing school with her. And her passion for that population really kind of transcends the medical concerns that they may or may not have, whether they're more med nav or more telemetry. She works in telemetry, but there's so many different places that you can latch onto, whether it's the population, the field, the environment, whatever it may be. But all that experience, you can teach with it. There's so many things laterally that you can go into research to make things better for that particular problem that just was a thorn in your side for 20 years. There's so many branches that they can take that bring them out of the context of that constant, it's called secondary trauma, that constant exposure of others' trauma on you.
That's such a valuable insight. I think anybody considering any career needs to ask this question of lateral mobility within the career. And some careers don't have as many opportunities as others. It's true. There's not a ton of opportunities for me to move laterally across disciplines, or even, to different tiers in the academic profession. It's not structured that way. But it's actually really important. I think it's because you do get a set of experience that kind of creates this umbrella around what you can do. And so you, over time, tend to feel that you can't move outside of that umbrella. So it's really valuable to know within that umbrella where you can go.
Oh, there's so many. I mean, like I said, there's fields that people, drug reps, medicine reps, pharmaceuticals, research, informatics, people that are very tech-minded, computer-minded, all the way to artistry, in terms of illustrators. There's even, for those people that are analytical minded, legal nurse consulting, consulting with attorneys that are handling either malpractice or, whatever medical litigation it might be. But they hire experienced nurses specific to a genre. Let's say you've spent 20 years in labor and delivery, and you've got some kind of medical litigation going on about a birth or about a whatever. That nurse has specialized experience and can read the chart, can look at the situation, and can give actual vetted guidance. And oftentimes testimony, expert witness testimony with regards to the standard of, what would be reasonably expected of a person with that licensure, with those tools, and with those protocols.
Yeah.
So there's so many, there's a ton, I don't even know. But there's just so many options, and it's not time gated. You could be a nurse for 5 years in care flight and decide this, I need to do something. That happened to me in critical care. After the pandemic, it was probably and towards the end of summer of 21, I started COVID nursing in March, the first week of March in 2020. And by the end of the summer in 21, I had realized for myself, I'd been injured in a code towards the beginning of 21. And I realized for myself at that point, I wasn't okay. I wasn't okay to be in critical care, not from a technical standpoint. The critical care aspect of it, wasn't the problem. The exposure to trauma for me and that context for me, I was at a point where I need to walk away from this. Not nursing, but I think my time in critical care, this is not good for my mental health, and I need to pivot. I need to look at other things. And I had the ability to do so. And in doing that, I became the chief nursing officer for a psychiatric hospital. And what I learned at that psychiatric hospital changed my life just as much as starting my research in 2019. So it just, every time you pick a different avenue or a genre, what you can glean from it and the positions that you're put in as a nurse, it's even more enrichment. Like, you don't know what you don't know, right? And you get into this and it's like, whoa, whole new things to take in, things to absorb, material to consume, and just new patient populations and interventions. And, nurses get all geeky and nerded out by that stuff and, dive right in. Like, it's amazing.
I'm so glad you're talking about that. I think it's so common that people can't see what else they could do. They've been doing the same thing for so long. They think that's the only thing that they're capable of doing, when in reality, doing it for so long has embedded skill sets and knowledge bases that allow you to go in many more directions than you can probably conceive of. That's a very hard thing to recognize, but it's really important.
A lot of nurses that don't know it. I mean, I'm hoping that they see your podcast as well. We try to tell them all the time, that there's other fields, and they're scared to step away from the bedside because the narrative of you're only a nurse if you're in a stack hospital and you're at the bedside is a false one. And we're not going to go into why it's there, but the different types of nursing, you're still a nurse. You're always going to be a nurse. Doesn't matter if you're psychiatric, home health, ICU, med surg, doesn't matter. You're still a nurse. And whether you're at the bedside or even if you're physically unable to be at the bedside, the million other ways that you can be a nurse does as much for patient lives and patient populations as every other avenue. And that's something that I wish, we could put on billboards everywhere so that nurses could actually branch out. Like, we need nurses in epidemiology and public health and community health so deeply, because there would be so many less patients that I'm seeing in the ICU and the ER. They would have had the preventative care, the education, the primary care, all that really rich therapeutic community engagement, public health based nursing. That's the foundation of why we were founded in the first place.
No, it really is an incredible field. And I'll go back to what I said at the beginning. I think it's one of these fields that genuinely, especially later in life, as you've acquired some more perspective, is much more likely to align with your value system than many other professions. I don't want to take too much of your time, Riva, but I do want to maybe end with just a couple of words about like the financial viability. My perception of nursing is that well, you've already touched upon it. There's a great need. We need more nurses. And so my guess is job security is relatively high. I also think that mobility is probably relatively high too. Like if you want to move geographically, it's probably possible. My profession is not. Like I can't easily pick up and
Yeah.
go to another university to do what I do. So I'm very geographically limited. But my guess is nursing is not like that. And my perception also is that it's probably not the highest paying profession out there, but it's probably not so bad either. So anyway, those are my thoughts.
In terms of mobility and job demand, absolutely. We across the I'm just going to speak for the United States because that's where we are. So for across the United States, once you get licensed, you don't have to take another exam. Like I know for attorneys, sometimes you have to sit for other actual bars, like because of the differences in laws. For registered nurses, you apply for a license in another state. They look at your credentials, the board certification of where you got your degree, what boards you sat for. They're all state boards, but and then some of the states have a compact. So if you live in a state that's part of a compact, you automatically have licensure in whatever other states are part of that compact. That's a whole political financial thing in terms of which states do and don't participate, but that's a thing. We're pushing for more compact licensed states because of nursing shortages, especially in rural areas. And as far as finances are concerned, it really depends on the region. For the most part, like here in Reno, we're big proponents of talking about salaries and talking about the differences in monetary values. So here in Reno, new nurses will probably start anywhere from 35 to 39, experienced nurses 55, 60. There are shift differentials. So if you work night shift, it's like an extra $4. If you work weekends, it's like an extra $2. That's pretty universal. California's cost of living is a little higher. So places like California, anywhere from just like basic starting rates, anywhere from like 70 to 90. And certain specialties, so bedside nursing at the hospital, because that's connected to like the highest billing rates, that just is what it is. Bedside nursing usually will pay more than what is non-bedside nursing, or positions that are outside of hospital, but it depends on the area. So it depends on the need. But more administrative positions, educator positions, things like that, clinical educators are slightly a little bit less than bedside. But the caveat for that is also they don't have the 12-hour shifts and patient assignments. So, it's a give and take. If you don't want to have 12-hour shifts and patient assignments, and for whatever reason, you're like, hey, I want to do 8/5s or 4/10s and not be assigned to a floor, it's a good trade-off. And then there's travel nursing, and travel nursing blew up, of course, during the pandemic. But for people for whom that kind of nomadic lifestyle fits their responsibilities and what they want to do, it's phenomenal. There's a lot of really good money to be made in travel nursing with reputable companies, and they have contracts that cover housing and sometimes travel, and usually the rates for travel nurses are a lot higher, and they're temporary assignments, so they're pretty much almost always 13 weeks for travel nurses. Sometimes they're called registry nurses. Strike nurses are very similar. So there are companies that solely supply large healthcare systems with strike nurses. So when you have staff that is on the line, and patient care is 24 hours a day, 7 days a week, forever. So you have to have nurses that come in. So the strike nurses actually enable line nurses, bedside nurses, to strike effectively. And that pushes policy, it pushes changes. It's just kind of how that political machine works. Travel nurses allow for hospitals that are having staffing issues or are understaffed to meet acceptable patient ratios and safety with acuity. But there's there's overseas, there's cruise ship nursing, Doctors Without Borders, there's relief missions. Oh, and there's events like we have Burning Man out here. Yeah, nurses will sign up and do shifts at Burning Man. It's usually the ER and ICU nurses hanging out with the paramedics. out there, but there's search and rescue. I mean, so all of those are pretty much the same in terms of range of mid-range, I guess, like 80s to 120-ish.
That's great. Yeah,
Yeah.
thank you, Riva. That was incredibly, I mean, this whole thing has been incredibly insightful. I can't think of somebody who would be better at talking about this than you have been. So thank you. But before we go, I want to do a quick plug for your podcast. You recently started a podcast about nursing.
Yeah, you touched on actually the crux of what I do in my research and what the podcast is about. In 2020, I founded an educational platform called the Code Team. And it's solely focused on healing the nurse. So all the things that we didn't learn in nursing school and all the things that we need to do in order to survive nursing and continue doing it, is the whole purpose of that education. So it's not educating nurses on how to care for other people better. It's just educating the nurse on how to take care of themselves. And the Ritual Nurse podcast is exactly that. It's exactly what it focuses on. All of my research on resiliency.
Does it focus on the bullying at all that you were talking about earlier?
Yeah.
Yeah.
I think my 5th episode just came out this morning. So in later episodes, I have some coursework and skill sets that teach people how to recognize it and set boundaries and understand the context in which it's occurring. Because role confusion and our autonomy is actually the switch that is causing, this type of lateral behavior. But yeah, it focuses on all that. We have humor. Nurses have weird sense of humor. So in addition to science and like holistic healing focus, there's humor and nurse stories, and
You got to have a sense of humor in that profession, I would think.
you have to. You have to. Sometimes you try not to say it out loud at family gatherings, but you have to. But yeah, it kind of wraps all that up into one, and it's short form episodes because as a nurse, when I commuted and when I worked, I loved podcasts, but I had to keep putting them down, and then I would never get back to it, and then I couldn't remember what I'd listened to. So they're specifically designed to be around 30 minutes. So 15-minute segment, a break, 15-minute segment, and work within how we nurses have to run around.
That's perfect. Yeah, I'll put a link on when I edit this. I'll put it on the screen so people can find it.
Thanks.
But thanks again, Riva. This is one of my favorite episodes. I'm looking forward to sharing it with my students.
Well, I am just overjoyed to be able to kind of talk about it, and I love nursing and love, getting into what makes it tick. And it was awesome getting to talk to you on something other than Facebook. And it was nice meeting you too, Jay.
As well.
I can't wait to see more episodes, and I hope that whoever watches this, that this helps you get excited about what you're doing in nursing, get excited about where to go in nursing, decide to pursue it, because it's an incredible field.